Assalamu alaikum students. Welcome to today's class. So just as a reminder, why my videos are important. They are very precise and exam oriented, and it's a very interesting and simple presentation. So please like, share, and subscribe to my channel. So we'll start with the topic today with a clinical case. So we have here today we have a 30-year-old male patient. Okay, there is no history of trauma. Patient is not giving any trauma history, but pain in the left shoulder joint. So, what history elicits is a patient had a nice sleep. When he got up from the sleep 10 days back, he had pain in the shoulder joint. He feel like shoulder is locked in adduction and internal rotation. So, it's locked in internal rotation and adduction means there is no abduction. Abduction is not there, and external rotation is also not there. So, patient is locked in internal rotation like this and adduction. So there is no any movement possible at the shoulder joint. So any locking in the relatively pain-free locking, but a limited movement or locking of the shoulder joint, it directs you there is some malalignment. So it's a dislocation. So there is no history of trauma, but during the sleep he had this attack. So the reason might be he had some subtle seizure activity during the sleep, so which he didn't recall or didn't remember. And during this, there is a contraction of the muscles and shoulder gave it way and it went into dislocation. So this is the common presentation of the posterior shoulder dislocation following seizures activity. So what is posterior shoulder dislocation? Posterior shoulder dislocation is the dislocation with head of humerus dislocate posteriorly. So in previous class, we have read the anterior shoulder dislocation. Here, the shoulder head of the humerus is displacing posteriorly in relation with the glenoid cavity. So glenoid cavity is anterior now and head of the humerus is posterior. This is the diagrammatic representation here. If you see, uh, this is how will you tell this is anterior part of this is coracoid. So coracoid is present anteriorly. So this is anterior shoulder dislocation. The shoulder will be here. So here the shoulder is behind the glenoid. So this is a posterior shoulder dislocation. So where head of the humerus lies posterior to the glenoid cavity. So it's a very not very common. It's a less common than anterior dislocation, far less common than anterior dislocation, and it is one of the common shoulder joint dislocation which is missed on clinical examination because most of the time patient won't have trauma history. It's just a seizure activity or patient some other activity where he had this dislocation and he just came to you after 2 or 3 days due to lack of locking of the movement. So 50% of traumatic shoulder posterior dislocations are missed in emergency. So what are the associated thing after the shoulder dislocation? It's the same as that of this one, the labral injury. Here the lesion is reverse Hill-Sachs. We have Hill-Sachs lesion in anterior shoulder dislocation. Here we have reverse Hill-Sachs lesion. And as I told before, when it comes out, it may stretch or damage the rotator cuff. So there will be labral injury. So here, if you see, this is anterior, this is posterior. So shoulder is moving posteriorly. So here is the injury to the posterior part of the labrum, posterior labral injury. And if you see, this is the posterior surface, this is anterior surface. So there is a dent in the anterior surface of the head. So we have reverse Hill-Sachs lesion here and labral injury. It's not exactly the Bankart lesion. It's something like a reverse Bankart lesion. So how will you classify it? It's acute versus chronic. So acute, it happens after the trauma, seizures, electric shock. Whereas chronic micro trauma. So during some sports activity, when you continuously, there is a stretching of the posterior capsule, so it will become more lax. So sometimes it gives way when patient is having internal rotation. So it may be presenting as an acute dislocation or chronic changes inside the capsule. So this is the mechanism of injury where there is a fall and the force are directing towards the shoulder joint, moving the shoulder joint posteriorly. So this is a classical trauma which causes posterior shoulder dislocation. So sometimes it may be involuntary or voluntary. Voluntary means in a patient who have habitual shoulder dislocation, they can dislocate posteriorly and will reduce WAC without any pain. So mechanism, there may be a direct trauma. So when patient is having acute trauma during the sports activity, or patient is having acute trauma during seizures or electric shock, that is acute shoulder dislocation. Sometimes no continuous stretching of the capsule. So if you see, this is your shoulder joint. Okay, here is the posterior capsule, here is the anterior capsule. So when you keep, when during some sports activity, this will stretch continuously. So in throw balls and all, so sometimes it may become so lax that it won't hold this one. So this head of the humerus, so it gives way easily. So this is one cause for chronic instability, where there is micro trauma happening on the posterior aspect of the capsule. So posterior aspect of the capsule, chronic stretching make the posterior capsule fractureless, and it may give way sometimes. So this is micro trauma or chronic trauma of the posterior capsules, which may result in posterior dislocation. Most common is trauma only, but seizures and electric shock, they have strong association with posterior shoulder dislocation, mostly in clonic phase of the seizures. So because when the limb is extended, internally rotated and adducted. So adducted, uh, when adducted, internally rotated and flexed, this is at the risk of dislocating posteriorly. So here, if you see, it goes into internal rotation, head give way. So adduction, internal rotation, and flexion at the shoulder joint is a high risk position of the shoulder joint to give way, and shoulder moves posteriorly and present as posterior shoulder dislocation. So how will you diagnose? So we'll take X-ray. So if you see, this is a normal X-ray. I told in the previous class also, when you take the shoulder joint X-ray, the glenoid and head of the humerus should interpose each other. So there is this much of coverage should be there. What happens in shoulder dislocation is, one thing is there is no coverage here, so it's called as empty glenoids. Glenoid looks completely empty. Second thing is, head is rotated so that it take appearance of electric bulb. So this is called as electric bulb sign, or electric bulb appearance on X-ray. So there are two classical findings on X-ray. One is electric bulb sign, light electric bulb sign, and empty glenoid. And if you want to see properly, you can take a axillary view, which is not possible every time due to the pain and limited abduction and rotation. Then the other thing is, when you suspect any glenoid, any injury to the head of the humerus, you need to take CT scan to know how much is the bone loss. And if you suspect the posterior labral tear or other rotator cuff injury, the other option is to do an MRI. So X-ray is very important, where you see light bulb sign and empty glenoid. So these are the two very, this one, if you see, this is empty glenoid, and this is light bulb sign. So it resembles like a light bulb. So these two are very important because they are often asked in your entrance also, that signs for posterior shoulder dislocation. So once you have diagnosed, you need to go for treatment. What is the treatment? So as I told, one is acute treatment. So we need to reduce it by traction countertraction method, by close reduction. So sometimes no patient present very late, like more than 3 or 4 weeks, and close reduction won't work. So we need to go for open reduction of the shoulder joint and reduce it. Then if you feel there is an injury to the labrum, then you need to go for open or arthroscopic repair. If you see here, this is how we do the repair. So there is a labral injury here, so they will repair it by putting the suture anchors in the sutures here. So when there is a labral injury, they have to pay. If the shoulder is damaged, head of the humerus is damaged more than 30% of the circumference. So this is like head of the humerus, more than 30%. This much amount is damaged, then you can't salvage the head. You need to go for hemiarthroplasty. hemiarthroplasty. But if the patient is having like 20% or 25%, we can go for subscapularis transfer. If you see here, this is the shoulder joint which has the lesion here. This is the reverse Hill-Sachs lesion along the anterior aspect of the shoulder. What we do is, this is the insertion in subscapularis inserting into the lesser tubercle. So we detach it and attach it or fix it over this one. So what is happening is, this shoulder, the dent is there, no, it is getting covered now and it's no more dent. And the movement also get restricted by this surgery, but it reduces the risk of patient developing recurrent shoulder dislocation. So this surgery is, we are transferring the subscapularis origin along with the bone block from the greater tuberosity. We are lesser tuberosity. We are just shifting the lateral tuberosity from lateral aspect of the humerus to anterior aspect in the groove or dent in the proximal humerus, head of the humerus. So this is the slide which explains you what difference between the anterior and posterior shoulder dislocation. It's very important because you should not get confused between the lesion of anterior and posterior shoulder dislocation. If you see here, this is an anterior shoulder dislocation. Here you have anteriorly we have subscapularis, posteriorly infraspinatus. And these are the labrum, and this is your head of the humerus. So what is happening in anterior shoulder dislocation? If you see in anterior shoulder dislocation, the head is moving outside. So in the movement of the head outside, it damaged the anterior glenoid and it damaged the posterior head. So we have Bankhart's lesion anterior glenoid and Hill-Sachs lesion along the posterior lateral aspect of the head. Whereas in case of posterior dislocation, if you see here, head has dislocated posteriorly. So during the course of displacement, it has damaged the posterior labrum and there is a dent in the anterior lateral aspect of the humerus. So it's a reverse Bankart lesion because Bankart lesion is anterior, present in anterior shoulder dislocation, and head is moving posteriorly, and the anterior surface of the head of the humerus is in opposition with the glenoid margin. So there is a dent on the anterior lateral aspect of the head. So reverse Hill-Sachs is over the anterior aspect of the head. Hill-Sachs is along the posterior aspect of the head. So this is all you need to remember regarding the posterior shoulder dislocation, and you need to know clearly what is the lesion and what are the differences between the lesion in anterior and posterior shoulder dislocation. So hope this slides explains you everything. Please like, subscribe, and share the channel. I'll cover inferior shoulder dislocation, otherwise called lexato erecta, in next class. Thank you.